cancer and environmental disasters in particular, but the worsening of our environment are really things that are great equalizers. And we recognize that, we're all kind of in this world together. We can really face these issues on a more human level. I think always recognizing that if we look at something and think, well, that doesn't relate to me, or that problem isn't my problem, it sure is.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Margaret Peggy Rosenzweig, ONS Scholar in Residence and Distinguished Service Professor in Nancy Glunt Hoffman Chair in Oncology Nursing at the University of Pittsburgh School of Nursing in Pennsylvania, about the impact of the environment on cancer outcomes, which is an ONS research priority. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Dr. Rosenzweig.
Hi, thanks for having me.
So to begin, can you briefly describe ONS's research priorities and what the significance is of the environmental priority?
This is really a new research priority for the Oncology Nursing Society. As you may know, the process of establishing these research priorities usually happens every 3 or so years. And there's a lot of preliminary work of talking to multiple parties of interest regarding what they believe the research priorities are, what nurses are seeing sort of in the clinics, in community, and really multiple opinions regarding where the direction of research for Oncology Nursing Society should go. And we heard this time loud and clear from researchers, from nurses in clinics and in the communities, from scholars and multiple other interested parties, that the environment in a very broad context was very much a concern, and specifically a concern for impact on cancer care delivery, quality, and outcomes. This time, the environmental priority became a reality. And it was because of the voices of everybody that we captured prior to the process of establishing and prioritizing where the research should be.
And so when ONS first established this research priority, what did oncology nurse scientists hope to better understand about the role of the environment in cancer outcomes?
When we first were in this meeting room where we brainstorm and then start the process of prioritization, the concepts related to environment were very much forward in any list. But in order to develop a meaningful and targetable list, we had to sort of take some space and think about the ways that the term environment could be used for oncology nurse scientists. We had to keep remembering what's the goal of establishing these priorities, and it's to provide a roadmap for oncology nursing science, for the scientists, and for the funders. While we're all concerned about the environment in many broad ways, our mandate was to develop priorities that could be testable and measurable and advance the science. To me, that was a very distinct difference, and it really helped me think about, well, what are the research questions that are evolving from our discussion in this process, and what's within the scope of nursing scholarship? Then I had to think about, I don't want to diminish nursing scholarship in any way, but there are some questions related to environment, like big cohort environmental questions that probably aren't best suited to the way that oncology nurse scientists are trained. And they're much more in the sort of epidemiologic realm, where you're talking about multi-year studies over the course even of several decades. So that can answer some of the environmental questions, but I didn't think that's where we wanted to place a priority. I kind of struggled back and forth. then as the group evolved in their work and we really thought these things through, and if you've been involved in these kinds of processes, that it just is really collective group thing, taking a breath, thinking things through, that these things start to evolve and you're able to come up with these categories that really all fell under the term environment, but were capturing what different people were telling us were concerns for them and that could be measurable and lent itself to research questions. So the three big categories that we did establish were first, the impact of neighborhood or area on cancer delivery and outcomes. The second, and along with that, was the impact of social determinants of health on cancer outcomes. So that's broadly environment. The second was related to very specifically weather-related emergencies and the delivery of cancer care and what happens in that context, which came up several times in this preliminary work. And lastly was the idea of misinformation and how patients, the whole interaction and education of patients in counseling, navigation of patients has changed due to patients' belief systems, their information that they bring about their cancer care, particularly, accelerated since 2020, and how that's really changed the face of cancer delivery, and that we know very little about why that's happening or how best to help our patients with the best information. That's kind of how we evolved. And that's where the three priorities under the big priority of environment was established.
Thank you. And I think that's so important because I am sure many people, when I hear just the word environment, I have an immediate sort of assumption of what that means. And often I think for many people, it is sort of climate related or weather related. And so I think this is a wonderful way to clearly define it. We are talking about sort of the environment that our patients and people experience their life. And what about those different environments or lenses through which we can define environment? How do we look at those unique circumstances specifically? So I really appreciate that definition.
And that's not to say that, for instance, reducing carbon footprint of our cancer care delivery isn't important and something that we can think about. And that was in the preliminary work that was mentioned, but that wasn't what we thought. It could always be a research question, but we thought it would not be a priority. Those were some of the difficult decisions that we had to make around that.
So how has nursing research helped expand our understanding of the roles of the environment and social disadvantage in cancer outcomes? And what have been some of maybe the most meaningful findings or advancements that you've noted?
Well, we've done, since the original priority paper in 2024, just this past year, we did an update of the research priorities so that the research priorities become a living, breathing document instead of just something that's sort of put onto the shelf and then taken out to write another one. I wanted to update the priorities to see what we've done and what's in the literature now about these topics. And clearly, what has exploded in the literature, kind of starting to at the time we wrote the first paper, but now is really out there, is a measure of social determinants on cancer outcomes. These are good studies to do, particularly if you're looking for data and data sets, because you can take readily available data. You can take some cancer outcome data, and you can take patient data related to home address or zip code or even larger geographic areas and kind of do correlational studies to see, does one impact the other? So it's a good exercise, a good training kind of study to do. And so there's been a lot of those in the literature, but they are very helpful because they're starting to define this idea that beyond the idea of just demographics, gender, age, race, that the whole concept of neighborhood and the influences of the neighborhood do impact cancer outcomes. And that's where we're seeing the sort of explosion in literature across multiple malignancies, stages of cancer, and across multiple questions, specific kinds of outcomes, everything from like quality of life to tumor progression. Essentially living in more highly deprived areas does contribute to worse cancer outcomes. I think there's some things to consider when you're thinking about these questions, but that's where we've seen the biggest advancements or finding is this consideration of social determinants, however that's going to be measured, and then looking at specific cancer outcomes.
Now, much of the literature uses the area deprivation index descriptively. From a nursing research perspective, what gaps remain in translating those findings into predictive tools or interventional focused studies?
You're right. The literature does use the area deprivation index very commonly now, and that's where the real explosion has been. You see all these studies relating the area deprivation index to different cancer outcomes. The area deprivation index is a composite measure of community characteristics, and it's pretty well established and pretty easy to use. It's at the census tract level, so you really get into some very granular specifics about the neighborhood. One of the criticisms of the area deprivation index is that it relies very, very heavily on home ownership and income. So it's a composite of several measures, but it is primarily garnered from those two indices. So there are other ways that you can measure community as well. And there are some other sort of options for researchers that may get to some of the things that you're looking for in the area deprivation index, or you can choose to use some other indices as well. There is something called the Childhood Opportunity Index, and that's particularly for pediatric patients, looks at other composites of a neighborhood that is less emphasis on just home ownership. It can incorporate other resources within the community. There's a Neighborhood Vulnerability Index, which is used through the CDC, and that incorporates, as opposed to the area deprivation index, it does incorporate race into the measurement of vulnerability. And that measurement has been used in preparation for disasters and in COVID preparation. So there's different things to consider. These are sometimes used interchangeably, and the correlations between these kinds of measures are not really that strong. The take-home message for researchers is you have to really think about what it is you want to measure, what's practical for you to measure. Do you have home addresses or do you just have zip code level? And then you have to think about and be clear in your writing exactly what you're measuring. This is using an area deprivation index is not a proxy for all social demographics, all social determinants, and it's not a proxy for income. It is a proxy for the area deprivation index, what you're measuring. So I think we just have to be clear about that because it is being used so frequently. I kind of see it being used in a very general manner, which is actually not that precise, but a wonderful tool and certainly much more granular than strictly traditional demographics.
Now, climate related disruptions perhaps were less prominent when many of these research priorities were established. How has oncology nursing research since then advanced our understanding of how disasters can affect treatment continuity and outcomes?
There's not a lot of literature around this specific topic, but there is growing literature around how cancer delivery can be better prepared for climate related disasters. There are some important review articles that are out talking about the drug delivery in disaster care. There's a good article by Pamela Dennett, who was published in Support of Care in Cancer, talking about climate disasters and oncology care. And that was really a systematic review, looking at published literature and kind of starting to classify where are the disruptions and how could we think about that from a research perspective. They ended up saying there's these patient level outcome disruptions that, of course, include treatment disruption, but also include this inability to communicate with the oncology care team, which is quite distressing. And there's a workforce disruption because there are very distressed clinicians who are experiencing the same climate related disaster in their own lives and feeling like they are torn between sort of their commitment to work and their commitment to family. And then, of course, the health system in their way that they have to adapt, shift services, recognizing that they need to have response disaster plans that are sort of difficult to maintain because thankfully there's not a lot of disasters. So they often sit on shelves and people are not ready to sort of implement these weather-related disaster plans. So there's a lot of areas that they define as vulnerable to weather-related disasters, but the literature is sort of just starting to grow in that regard. There certainly could be more.
So it sounds like training and preparedness are gaps that have been noted. Where does nursing research need to focus, maybe to move from just identifying those problems to actually testing effective disaster preparedness models?
I think for education, there's some really good papers that are out now. There's one by Dyke and McGowan, and that's in CJON, the Clinical Journal of Oncology Nursing. And they talk about environmental risk factors. Now, they're talking about specifically things that nurses face in terms of carcinogenic risk and environment. But the kind of paper that everybody recognizes as really an excellent paper and something that really summarizes a lot of the concerns is the impact of climate change across the continuum, with Anne-Marie Walton as the lead author. That group, Walton, Stanifer, and Wilson, just had a webinar around these same issues. It was also quite informative. Their paper states that it's really part of the ANA's call to action for all nurses to be aware of environmental health and its effects, and that oncology nursing is really following in those footsteps by being prepared. They write across the continuum many considerations for environmental considerations in the delivery of oncology nursing. It's a really, for education and to kind of get started in this area, I think it's a really good, informative paper, and one that isn't so dire. It is a little bit uplifting in terms of what we can do. For research, I think there's a lot of things that could be considered. One of them is the testing and, of course, the outcomes of different preparedness models. And that's tough because, of course, how do you test preparedness for something that happens on a very infrequent measure? And so there's different levels of preparedness that you can think about. There was one study I was looking at that's really interesting. It's called a difference in differences study. The value of this is that it's a retrospective study that you can do from, for instance, two similar regions where one has experienced a disaster and one hasn't. You might take a hurricane area, say North Carolina, and pick one area that's had a hurricane and one that hasn't, and try to make those as similar as possible. And then look through records through, it's really a health service kind of project that you can look at how much disruption there was in the delivery of care, how long it was until people were able to reestablish care. And you can look at sort of tumor information over the long term to see what these disruptions meant. So you're using existing data. It can be applied retrospectively. And it's also really well suited with an equity lens because you can look at large population without having to sort of search out specific hospitals or clinics. Something like that, really reading about the methodology that you can use to start to look at not just what are the problems, but how can we start to establish rigorous methodology to look at the outcomes of these disruptions, and then start to plan, okay, how can we look at a preparedness plan that isn't just something on paper, but that could really be effective, and maybe do some design around that. What do patients think about a plan? What do the providers think about a plan that could be implemented? Maybe prepare by starting with human-centered design and really getting something that everybody buys into. So there's a lot of work that can be done even without facing an immediate disaster. And in fact, should be done so that the resources are there and it can be done in a thoughtful manner.
Right. We can't wait until the next disaster comes to start to try to be ready to study it. So those are some wonderful ideas and just different perspectives to think about ways that we can continue to grow that body of knowledge. So moving on now to how you described sort of another environment, which is the environment of kind of communication and information. The 2024 to 2027 research priorities perhaps couldn't have fully anticipated the scale and the growth of misinformation challenges that we first saw during the COVID-19 pandemic and have persisted. How has oncology nursing research contributed to understanding the impact of misinformation on patient trust and decision making?
So, in our evaluation or sort of midterm evaluation of this, the honest assessment is that the contribution overall for oncology scientists, as well as others, has been relatively modest. Oncology nursing has been a little bit more at the margins of some misinformation rather than kind of diving into what's happening right now. So, sort of traditionally, there has been vaccine hesitancy. We've seen that documented for many decades. And that's where oncology nursing seems to have sort of the biggest footprint. And then that extended into the COVID-19 vaccine. But the sort of more than descriptive work over which patients were hesitant, it hasn't really been established. And then clinical trial participation in this trust has been a large area for oncology nursing, and that continues. But some of the more current research in clinical trial participation has been around misinformation that's most damaging, not when it sort of introduces something completely new or a new untruth, but when it might sort of foster something that patients believe have legitimate historic roots. So if somebody is going to say, well, it's just like, and now many people will say, well, it's just like those COVID vaccines. See what happened with those, as if that was not successful, as if it made the country sick to have these COVID vaccines. So it kind of like plays on other myths that are out there rather than trying to establish something that's entirely new and untrue. So there's a lot of gaps here. There's a lot of gaps about what can be done. There's a lot of gaps about how to measure this. And there's a lot of gaps about just the mechanism question of, we know that misinformation sort of affects, well, it doesn't sort of, it affects patients' decisions. So you have a patient with full capacity who is making decisions that you believe as a nurse are sort of based on falsehoods and something that a family member has told them or that they've read. But often we don't know the how, like how did they go from accepting sort of what their oncologist has always told them to disbelieving what is being told about cancer care or about science or about how their particular drugs have been developed. And was it through changed emotions? Was it through different norms? Was it because they now belong to groups that believe this? I think we could begin to explore some of the mechanisms behind the changing beliefs without becoming political or disrespectful to patients. I think out of a genuine curiosity as to why do you believe what you do rather than I'm going to change your mind by proving that you're wrong. And that can be really hard, particularly if you believe something so strongly. Like, I really believe this drug is the best thing for you. And the patient will be saying, no, I don't trust that you are sort of looking out for me. I think that can be really difficult. So we always have to go with an openness, respect in thinking about a research study that may really explore more the mechanism than even the belief itself. There's a lot of work to do here.
Absolutely. And it truly is equal parts fascinating, frustrating, I think, for many clinicians. And certainly we encounter patients at the point of care that are sometimes grappling with misinformation. And certainly we need to be able to help nurses and support them in those discussions. But then it also makes me think, how many patients do we never actually even meet because they are so distrustful that they don't engage with the system at all?
Sometimes it's also when you talk to patients, it's like the casual nature. This is what astounds me, the casual nature by which they will completely discount their literal life-saving drugs
Mm-hmm.
to me
Mm-hmm.
and say, oh, I'm taking this. I'm taking this. It does make me have to step back, bite my tongue, and say, let me explore this with you. I heard a great lecture a couple months ago by pediatricians who say that we are being told by the healthcare systems in which we work to be risk averse, that we don't want to engage with patients because, it could be political, it could make patients mad. And they don't want anything sort of out there in the media saying, oh, this provider from this health system, is telling people this. But they say we are squandering our good nature, our good reputations, and the trust that patients have in us as doctors and nurses by not exploring with patients why they're believing what they believe. And they really made the point that now they're pediatricians, so they were talking about childhood vaccines. They say to their patient, I recommend this for you, and this is what I would do for my own family. This is what I do for my children. And they believe that this is the strongest messaging that can be done. We have to use our own relationships that we have, that we're sort of shying away from engaging with people, and use that to make these recommendations. And they say, get on social media, be that person out there. And, you see some nurses doing that and some physicians, but you don't see a whole bunch of people doing that because we are sort of told by our health systems, oh, don't engage, don't engage. And they were just saying that perhaps is that when you have all these influencers with the whole world behind them, we're not doing very well in this battle.
Right. We have to sort of match the reach and the voice that they're hearing from other opinions. We need to be able to reach them in the same way. Do you see any other gaps that might remain in nursing research that relate to health literacy, digital environments, maybe culturally tailored communication, and especially for perhaps underserved populations?
We do have to look at all of these things through an equity lens, that not every population has the same access to information, and that there might be different levels of disbelief, but for different reasons. And again, getting to that mechanism that can be really, really helpful. I think this is just a great area to explore. It's something that I do think patients would talk about. I think it's a good, particularly for more novice nurse researchers, this is something that might be kind of comfortable to talk about. And it could be so valuable in the literature to kind of know, this is kind of how best to speak with people. So you could make it almost a primer on best practice, as well as some outcomes. Not that your sole intent is to change minds, but to at least have a conversation with people and an ongoing conversation about some choices that they make.
From a research standpoint, what kinds of interventions or interventional studies do you think we still need to move toward actively countering misinformation in oncology care?
Interventional studies, I don't know yet. I'm not sure exactly what we can do. Once someone, for instance, is recommended to have chemotherapy, we did this study in my own research program for Black women recommended to have chemotherapy. So after the recommendation was made, we randomized to traditional sort of chemotherapy education versus sitting down with a patient and saying, let's go over the recommendation that was just made. Here's the size of your tumor. And then, having a ruler and actually showing the size of a breast cancer tumor. Here's what lymph nodes look like. You're HER2 positive. Here's what it means to be HER2 positive, and sort of showing just a diagram of what that receptor might look like. That study was really highly effective in getting patients to come for recommended chemotherapy. The intervention took about 20 minutes, but it wasn't just here's all the information, but it was also an exploration of tell me what you're thinking about chemotherapy and what are some ideas that people have told you, kind of exploring that idea of why would you be hesitant. And it was never to talk anybody into chemotherapy. It was just not to allow somebody to say, nope, not for me, without really exploring the reason why the chemotherapy was being given, and then kind of exploring with them what fears and concerns they had. So something like that. Now, the problem is who's going to do this, because the clinics are so busy and chemotherapy education is already kind of very difficult to fit in before people start chemotherapy. So perhaps, an expanded role of patient educators or, just somebody in the clinic who is not necessarily at a professional level and highly paid, but maybe more of an educator who could really sit down and go over why recommendations are made and exploring with people kind of their thoughts and fears around the recommendation. So those kinds of things could be measured in an interventional sense. I do think we're into a whole world now of it's us against them. And I'm not sure who the us is and who the them is, but it's just a sense of don't believe anything that's told to you. Again, I think we have to have a better understanding of this mechanism before we can really design interventions. And it is tricky. We're not in the business of trying to change people's minds who have made a decision when they have full capacity. We have to be careful about that. But we also want to be sure people are making the best informed decision. I'm not sure beyond that traditional education, a really cool design, but I would sure be open to hearing about it.
You always hear every year, oh, nurses rank number one as the most trusted healthcare professionals. And then when we encounter, and nurses and physicians clearly are different roles and patients interact and perceive those relationships perhaps differently as well. But it does always kind of just strike me as very interesting is that nurses are still thought of as very trustworthy, but even we struggle with connecting with patients who already come to us with their preconceived notions of if this is really a helpful treatment or if you hear lots of, oh, it's just big pharma. And, you hear all the things of people just assume that someone is being dishonest with them or there's some other ulterior motive. And so it's just a very challenging space to be in as a clinician of truly wanting the best for patients and trying to share that information. And as you said, not convince them, not to coerce them, but you just want to make sure that they are hearing you and are understanding what you're telling them. And then they are free to make that decision. But it is certainly a challenging time to be in healthcare with this misinformation.
It really is. It's added a layer of complexity that I think is very frustrating to clinicians. I just see that frustration all the time.
Where do you think oncology nursing research still needs the greatest investment to meaningfully change outcomes rather than simply documenting disparities that we are seeing?
I think this has to do a lot with environment. And after all these years in oncology nursing, I am convinced that we have to get the consideration of neighborhood. I think we do have to get back to the neighborhood level in order to boost the resilience of communities against cancer throughout the cancer trajectory. So the example I give is traditionally, if we want to do an intervention of mindfulness, we might, in a traditional research setting, get our, hopefully, funding. And then we would say, okay, I'm going to hire an interventionist. And maybe I want to do yoga or mindfulness exercise of some. And you generally will hire somebody who's at the university to kind of do that yoga or mindfulness or whatever it is, and train your interventionist and do your study. And if it's directed at Black women or underserved women or Hispanic women, whatever it is, you would then recruit them from the cancer centers. And I think we have to put that on its head and say, let's go to the community, not necessarily to find patients with cancer, because that can be very difficult, but really to say, why wouldn't we have interventions at the community level? And why wouldn't we be training the people within the community? So say somebody has a gym in the community, in a Black community, why wouldn't we be asking those people in the gym, the people who own the gym, to say, would you be willing to be an interventionist for us? Could we train you and pay you to be a cancer yoga interventionist, and that you would have this expertise and you could do the intervention here so that it's not inconvenient for the patients and it strengthens the community in their ability to say, yeah, we have resources to deal with cancer. And you could do that for psychologists. You could do that at the barbershops or hair salon. You could train people or educate people or whatever it is. But in turn, you could boost the community's resilience against cancer across the trajectory and not always rely on the cancer centers that are straining to even get basic quality care done and then always being criticized for you're not doing enough, which they aren't, but it's because the needs are so great. Let's take some of this to the community and boost the community in that way. I really feel like we have to think about just boots on the ground outside of the cancer center instead of just documenting disparities or even doing interventional work, but still within our little ivory towers.
And as you said, recognizing that the abilities, the skill sets, the availability, the convenience of those resources or those people that already exist in those same communities. And it ends up leveraging, and extending the reach because of the resources that otherwise we wouldn't have access to. So I love that idea.
You can use like a YMCA or in so many communities, and they're very open. This is part of their mission as well. So it works really well.
What unanswered questions do you think should define the next generation of oncology nursing research related to environmental influences on cancer outcomes?
Oh my goodness. I think all of these questions can be explored a great deal more. One of the things we didn't talk about that was of great importance to oncology nurses, particularly oncology nurses at the chair side or bedside, was this idea of carbon footprint, just the waste of cancer care delivery and how we can think about that. You see the work of many in looking at the specific environmental risks to nurses through the toxic chemicals to which we're exposed, but then thinking about the people who aren't as protected as nurses and the environmental workers who are usually contracted out or not in unions, don't have some of the same protections that nurses or other healthcare workers might have. And they're exposed to the chemicals without proper training or sometimes without protection. All of these things are very much worthy of an oncology nursing voice elevating these questions and saying, how can we study this? How can we best sort of mitigate some of these risks? Oncology nursing is just, we have to use our good, as you said, our respect and good name in elevating all of these questions. This can be so daunting that you could almost just shy away from it because it feels like, what role could I possibly have as one person in fighting all of this? The idea of just the environment becomes so overwhelming. But I do want to recommend this book that was recommended in the webinar that I mentioned. And I did get it because they mentioned it. It is so inspiring. It's called What If We Get It Right? It's by Anna Johnson, and it's different writings, some poetry, some short essays, some lists of things about ways that there can be environmental justice, there can be environmental mitigation. It's not really related to healthcare and it's not specifically related to cancer, but it does feel like here's some solutions, here's some positivity in this otherwise sort of bleak environment, particularly these days. It was recommended to me and I appreciate it. And it does make me feel a little better, I guess.
Definitely something maybe we could all use a little bit of encouragement on. So thank you for that recommendation. Well, Peggy, as we reach the end of our episode, we'd like to always run through a series of just some quick questions to help summarize some of the great topics that we've covered today. So to start that off, how do you think healthcare professionals can evaluate their hidden or their implicit bias they might hold about environmental impacts on cancer care?
It's probably related to the implicit bias that we carry about those people have this happening to them because, they might not have worked harder or hard enough, or, that's not me. That doesn't really relate to me. And I think two things, cancer and environmental disasters in particular, but the worsening of our environment are really things that are great equalizers. And we recognize that, we're all kind of in this world together. We can really face these issues on a more human level. I think always recognizing that if we look at something and think, well, that doesn't relate to me, or that problem really isn't my problem, it sure is. And recognizing sort of the human nature of us all, I think is one thing that we can all work on at all times.
What are some common misconceptions about these environmental effects?
I think that it's insurmountable, that we can't do anything and we might as well not even try. And when you see, no, there are people who are out there asking the questions, trying to measure to what are we exposed, trying to better understand patients' viewpoints. Of course, we can't, it's enormous, but little by little, everybody kind of working on small things and recognizing that we're doing that can really be inspiring and, a force for good. So I think the fact that people think there's nothing I can do, this is just hopeless, it's just not true. And we really have to sort of step up And even if you're not feeling it in your heart, feel like, I really need to do something.
Fake it till you make it, right? Like,
Right. Yeah, exactly.
What's something about this topic that's not often discussed, but you wish people knew more about?
I don't know a lot about this issue of carbon footprint and the waste of healthcare, in particular cancer care. And so I do wish that I knew more about that. And, I want to become more informed about that. Maybe on a grand scale, there's not a whole lot I could do, but at my local practice, and are there suggestions I can make? Is there a committee that I can join? Is there a committee I could start? Something in which we could even marginally reduce some of the waste, I think would be really important. It's not one of our research priorities, but I think when you think about this issue of environment, it certainly could be important.
What additional training or education do oncology nurses need to stay current on this topic?
It's so evolving that I think you really do have to put out some literature searches and reminders to yourself to get literature as it's published so that you can stay current. So in this issue, for instance, looking at neighborhood and area deprivation, these kinds of papers are coming along all the time. So you might want to have the alerts so that you can see, where is this evolving, what would be redundant at this point, and where should the science go forward. You just have to keep up with it right now in order to see, well, if I want to do something in this area, what would be sort of cutting edge and building on the science that's being done? Because in some areas it's evolving very quickly. In others, for instance, in this preparedness kind of area, it's really not moving that quickly.
Well, Peggy, thank you again so much for joining us today on the podcast. It's been wonderful to talk with you about this research priority and just hear your insight and your perspective. It's certainly taught me a lot.
Thank you.
Thank you so much. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.